Okay, let's go ahead. So we'll be looking at our periapical radiolucencies. So we look at the commonest. So our objectives will be to outline different types of radiolucent lesions associated with root apices. And we also study the radiographic features of various radiolucent periapical lesions. So we can simply classify them into false and true ones. So the false ones are just the normal radiolucent appearances on images. And then the true now, the periapical radiolucencies that we need to look at are the ones that are pathologic, and they can be divided into inflammatory, fibroosseous, cyst and tumors. So amongst the normal radiolucencies that you may come across when you're looking at radiographs would be the bone marrow spaces, the foramina, such as the mental foramen, incisive foramen, and then different fossa like the sublingual fossa or submandibular fossa. You may also find canals like the nasolacrimal canal, the mandibular canal, that's the inferior alveolar dental nerve canal, and then dental papilla of developing teeth. For example, before the calcification starts to happen, you'll just find a crypt that is radiolucent and looking empty. And then others would be artifacts like processing errors, where we have like developer splashes on fumes when you're developing. So an example like this, we have open apices. Look at that panoramic image shown. So you find that the lower 7 is developing. The root development is not yet complete. And then apically, the apices are open. So they appear as radiolucent areas. So do not confuse that with an infection, a periapical infection. And then the mental foramen, there is a mental foramen. Mental foramen from the right side, the other one on the left side. It's normally below the premolars. So here we can see them just directly below the second premolar, or slightly distal to the second lower premolar. So get to know the normal location of the mental foramen so that you don't confuse it with a periapical infection. And then here we have the lingual foramen, which is around the geniotubercles. The geniotubercles are the radiopaque area around that foramen. So that's the lingual foramen. You also find it apical to the lower incisors. So that's a normal occurrence. So others would be the dental papilla. Let me enlarge. So look at the area of that second deciduous molar. And then periapically, we have the premolar that's developing, and you can see an area of a radiolucency. Coincidentally, also that tooth looks carious, and probably it could also be infection happening in the interradicular area of that tooth. Look at the other side. The second premolar has just calcified, and we have the crown is forming, but surrounded by an area that is a radiolucent. Then let's now look at the pathologic types, starting the inflammatory. So the inflammatory types are the ones that are most common. So we have the acute types. For example, acute epicoperiodontitis, acute apical abscess. And then the chronic types would be chronic apical abscess and periapical granuloma and a radicular cyst. So this, you are likely to encounter them most of the times when you are assessing patients and you're looking at radiographs. So we look at some of these lesions. So we start with the acute epicoperiodontitis. Acute epicoperiodontitis. What is the etiology? So these are inflammatory changes in the periapical area due to edema of the periapical tissues, and they may result from a pulpal generation. This is after probably a patient has had a carious tooth, and then they get pulpitis, the pulp gets infected, and it starts degenerating, and the periapical tissues become inflamed. It can also result from periodontitis, that is the infection of the periodontal ligament space. And the infection now of the periodontium. Then from there, you'll find patients who have deep pockets, and then these pockets are going to be now serve as the entry for infection that moves all the way to the periapical area, and you get an infection. And then you can also get epicoperiodontitis from trauma, especially trauma from occlusion. For example, if you do a filling and you have a high spot and the patient exerts excessive pressure on a particular tooth, so you start having the periodontium is going to react, and what you find later, it will be epicoperiodontitis. It can also be due to accidents leading to fractures. So there is a radiograph to show you the radiological signs of apical periodontitis. So you'll find there is a widening of the apical periodontal ligament space. Look at that tooth. It has a large carious lesion distally, and this infection has spread to the pulp and to the periapical tissues. So if you look carefully, you'll be able to appreciate that there is slight widening of the periodontal ligament space. That is what we call the apical periodontitis. So when it is acute, now you deduce this from the symptoms that the patient comes with. So the patient will have a lot of pain, and probably the tooth will also be a bit extruded from the socket. So when you percuss that tooth, it is very painful. It is tethered to percussion. So that's apical periodontitis. Initially, it may not have any radiological features, but with time they form. And this now transforms now to a chronic state in case nothing is done. So another example there showing apical periodontitis. Look at that 6. It has a large carious lesion, which is communicating with the pulp chamber, the pulp canal, and then periapically you will find that you have this radiolucencies around the tooth. That's the widening of the periodontal ligament space. And if you look carefully, you will find that there is also sclerosis happening around the roots of those teeth. Let's see, what else do we have? Okay, then from there, We have another example here. This is a patient who experienced trauma. This is a young patient. The third molars are still developing. So if you look at the body of the mandible, look at that area where we have the 6 there. We have this trauma and a fracture line that is extending. It's moving through the periodontal ligament space and going all the way to the body of the mandible. You can see it on the 7th there. So this is also responsible of causing apical periodontitis. Okay, from there, if nothing is done to that tooth, it may develop an acute apical abscess. So this will result from necrosis of the pulp, and you end up with pus formation. So initially, there are no radiological features, but later you'll find a diffuse radiolucent lesion which forms periapically. Then the acute abscess may also proceed to a chronic apical abscess, or a chronic abscess may also result from a granuloma, where maybe you had an existing infection, then a granuloma formed, and then later you can get the reactivation now of that infection becomes active when you get a chronic abscess, and the patient presents to you with a swelling and even with pus. So what you find is that you still have a widened periodontal ligament space. Then periapically, you'll find a diffuse radiolucent lesion, which blends with the surrounding bone. And then you may also find a radiolucent canals extending towards the surface of the bone. So probably this one, you may be able to appreciate it if you have a 3D from a CBCT or a CT image. Let me enlarge. Look at that arrow. The arrow is pointing at a tooth there. These are premolar. And then you find that we have a enlarged periodontal ligament space. So with radiology, you have to accustom your eyes to looking at images so that you can understand what is normal and what is abnormal. So for now, maybe you may not appreciate that there is widened periodontal ligament space, but if you compare with the other teeth that are not symptomatic, that do not have any symptoms, then you'll appreciate that there is widening. So here we have widening of the periodontal ligament space, and then we have a radiolucency at the periapical area. So this is likely to be an abscess, and you have to combine it with the symptoms that you elicit, the signs and symptoms that you get when you do your history, when you examine the patient, then you do the radiograph, then you're able to interpret this. Unfortunately, even a granuloma will appear the same, but you know that it's an abscess, especially when you find there is pus and there is that swelling. Okay, so over time, those periapical infections, they proceed and form a periapical granuloma. So this is just a granulation tissue which forms apically, just trying to protect the rest of the tissues from this irritation that is coming from the pulp. So you have granulation tissue forming periapically, and there are times when you actually find this granuloma. When you do an extraction of a tooth, then you'll find that periapically at the apical end, you have this soft, small mass of tissue that's attached to the root. So that's a granuloma. Other radiographic features would be loss of the lamina dura, and then you find the radiolucency. Most times it is well defined, but could also have ill-defined borders. It's usually about 1.5 centimeter. And then you may also find a root resorption that may be present. And note that the periapical granuloma may also form laterally due to necrosis of a lateral canal. Okay, we have a radiograph here. So this is a cropped panoramic image and still of a young person, a teenager, but their 6 is grossly carious. It has even fractured. You can see that the mesial and the distal roots are separated. It's fractured. There is even interradicular, these radiolucencies there between the roots. There is infection there. And then periapically, you find that there is this radiolucent lesion around the root. So with this, you find that you can't find the lamina dura. Compare it with the 7. Let me enlarge. Okay, so compare it with the 7. This 7, you can see the lamina dura, which is that radiopaque bone that surrounds the alveolar bone. The radiopaque area, that is a thick bone, cortical bone. So when you look at this tooth, you cannot find that radio opacity that borders the periodontal ligament space. And you can see that the periodontal ligament space is widened. And what's also happening is there's also resorption of the root. There's resorption of the root in that area. Looking at the 7 is still developing. So what you see the apices of the 7, these are open apices. The tooth is still forming, and that is normal. Other radiolucent areas that you find in bone would be like the bone marrow. So that is normal. It's not pathological. Then from there,
I have a question.
Could we finish? Then you ask the question.
Okay, thank you.
Then from there, a radicular cyst forms. So this may develop from a pre-existing granuloma, and this is due to stimulation of epithelial cell rest. What are the radiologic features? So now the radiolucency will be well demarcated, maybe round or ovoid, and then it has a radiopaque margin, which is continuous with the lamina dura. You may also get resorption of the roots, that is in long-standing types of radicular cysts. And then as it grows bigger and wider, you can get divergence of the roots. That's an image there to show you a radicular cyst. So it is well defined, and you can see the radiopaque margin, which we didn't find in a granuloma. There's a radiopaque margin there, and this is associated with teeth that have been root treated. So that's a radicular cyst. And remember, when you remove the teeth and the radicular cyst is left, you form a residual cyst. Okay, so if you have had now this patient who has had a root canal treatment done and it's successful, then you go ahead and you enucleate the cyst. You remove the cyst and clean up the area. So what happens is that you get healing of that area. It can heal by forming bone, or it can heal through fibrous tissue. And that's when you get an apical scar. So with the apical scar, this is an area which is which has healed. It's an area which has healed, and it's made of collagen fibers. And if you do the histology, you'll find that there are no inflammatory cells. So again, you have to do your history well. do the clinical examination and do the radiograph for you now to conclude whether is this a scar or is it a granuloma. So such a patient who has an apical scar, they may not have any other symptoms. The tooth will not be sensitive. There'll be no complaints of pain, and there'll be no tenderness to percussion. So you may just find it as an incidental finding. Okay. Then now, other lesions that may give you a periapical radiolucencies will be fibroosseous lesions, and especially like periapical segmental dysplasia. These fibroosseous lesions, when they start in the early stages, they are radiolucent, and then in the middle stage, you start forming some calcified tissue, so they become mixed, and then in the late stages it becomes completely calcified, so you find a radiopaque lesion. So in the early stages of periapical segmental dysplasia, it will be radiolucent, but what you find is that the patient will not have any symptoms of pain. In fact, this will be incidental findings. And then the periodontal ligament space will be intact, it will not be widened. And then these radiolucencies, they do not have any cortication. It's just non-corticated, smooth outline. So this is an example. So you just find that the tooth is okay. There are no cavities, no large fillings, no restorations, no signs of trauma. And then, but there's a radiolucency there. And then you find that it's not corticated, and the periodontal ligament space is not widened. It compares the same with the surrounding teeth. Then we have other uncommon lesions which may present with the radiolucencies in the maxilla or in the mandible. So one of them is osteomyelitis, a dentigerous cyst of an underlying tooth. So mostly dentigerous cysts, you'll find them as pericoronal radiolucencies, but if it involves an underlying tooth, then to be periapical to like a deciduous tooth. Then simple bone cysts, odontogenic tumors such as amyloblastoma, odontogenic myxoma, or central giant cell granuloma, early cementosfine fibroma, or primary malignant tumors, and metastatic tumors. So this is an example of osteomyelitis, where we have diffuse radiolucencies in the affected area. So here you'll find multiple radiolucencies, and probably you'll find that this patient has pain, and they have other symptoms like fever, they are febrile, they're feeling sick. And then odontogenic tumors and cysts. So those will also appear as radiolucencies. There are those that are unilocular, others are multilocular. So this is one that is unilocular, and it's a radiolucency that is periapical. So there are many tumors that will present this way. So the only way you distinguish them is mostly through histology. And then metastasis. This was a case whereby a hepatocellular carcinoma had spread up to the jaws. So when you look at that panoramic image, periapical to the 7, you have a radiolucent lesion over there. So that's why it's important for you to do a good history, and the medical history comes in very handy, because this patient is likely maybe to tell you that they had been treated or they are being treated for a problem they have with the liver or with any other part of the body, because you can also have metastases like from the breast cancer. Therefore, a good history is very good. And then you also examine the patient well, and most likely you may find that the tooth has no symptoms, the filling is intact, and there is no secondary caries. So it's important for you to do a good history before you conclude that that is a radiolucent lesions, which is before you conclude that it is odontogenic, and therefore you need to do something to the tooth. Okay, so that forms the end of our lecture. Let me stop the YouTube live, then we can do the questions.